Hello, everyone, and welcome to webinar number 10 in our AFBSS webinar series. Today's topic is Models for Mobile Opioid Treatment Programs, or OTPs. And now, without further ado, I'd love to hand it over to our presenters, Dr. Anika Alfonso and Debbie Witham.
I will start by introducing myself. My name is Anika Alfonso. I'm a physician principal at Health Management Associates. We are a national research and consulting firm. I am an internal medicine trained addiction medicine physician and have been board certified in addiction since 2010. And with that, I'll pass it to my colleague.
Hi, I'm Debbie Witham. I am a principal in HMA's Washington, D.C. office. Prior to coming to HMA, I worked at CARF where I oversaw the standards development, training, and our relationship with SAMHSA for the opioid treatment program accreditation area, as well as the federal policy stuff for all of our accreditation areas. And so a lot of that was as the DEA was lifting the moratorium, starting to thinking about how we were developing the standards for mobile opioid treatment programs. Prior to that, oversaw full continued behavioral health, primary care, housing services in the Bronx, including a very large opioid treatment program. Always wanted to have a mobile OTP because we had many people who had challenges in making it, even in a large urban area. So this is a topic I love to talk about. So thank you for having me. And I'll turn it back to Mika for the agenda.
And for today's agenda, we're just going to give an overview of OTP services and kind of the evolution of OTPs and the OTP services and talk about mobile OTPs, increasing engagement and low barrier treatment, specifically in the mobile OTP setting, barriers to and benefits of implementation. And then, as I said, we'll try to leave some time for question and answers. And our learning objectives for the day are we identify at least 2 major milestones in the evolution of mobile OTP services, list at least 3 tenets or principles of low barrier treatment, identify at least 2 common barriers and strategies for addressing those barriers, and identify at least 2 potential benefits of implementing mobile OTP approaches. With that, I'll turn it back to Debbie.
All right. So for the overview, the evolution of OTP services and mobile services. So we're going to go into a little bit of how OTPs kind of developed overall and then get into how they evolved to mobile opioid treatment programs. Next slide, please. So methadone has been around for a very long time. It is one of the most studied treatments that we have for treating addiction. In 1937, it was synthesized by German scientists. In 1947, introduced to the United States as an analgesic for pain. Then in 1965, Vincent Dole and Marie Neiswander, 2 pioneers in the treatment of opioid use disorder in the U.S., developed this through a clinical trial with methadone to treat heroin use. And then in 1972, it became a treatment for OUD, but it was restricted to licensed opioid treatment programs, oftentimes back in that time called MMTPs or methadone maintenance treatment programs or just methadone clinics. Next slide, please. All right. So some of the benefits of methadone in treating opioid use disorder is we see a decrease in illicit opioid use. We see an increase in treatment engagement. People's cravings are managed, their withdrawal is managed. They are able to engage in treatment and in recovery activities. 2 to 3 times reduction in risk of mortality. That's huge, right? So we know that this is a life-saving medication. Those who receive medications for opioid use disorder are 75% less likely to have an addiction-related death than those who do not receive MOUD. So we know that getting this out into the community is incredibly important and life-saving. And also from a public health perspective, we're decreasing transmission of infectious disease, HIV and hepatitis, 3.5% versus 22% HIV seroconversion rate. We see a decrease in criminal recidivism. We do a lot of this work across the country within criminal legal settings, and we often see those settings really even tracking within their own detention centers and jails, the rate of recidivism once people are started on medication and seeing that go down, but also national, international studies show that as well. We see an increase in employment. Our OTP of all of our addiction treatment programs always had the highest rate of people who were employed. improve birth outcomes amongst pregnant persons with OUD. We know that, and that is one thing that we know definitely for sure has been studied over decades, is that medications for addiction treatment are the standard of care for persons who are pregnant and with an opioid use disorder. So next slide, please. One of the challenges in accessing methadone is that it is highly regulated. So it can only be dispensed in a federally certified opioid treatment program called an NTP, or narcotic treatment program, in California. They have to be accredited by a SAMHSA approved accrediting body, which is CARF, Joint Commission, Council on Accreditation, or the National Commission on Correctional Health. Then they have to be certified by SAMHSA. They have to be licensed by the state in which they operate. And then every state has a state opioid treatment authority who is responsible for ensuring that the laws and regulations of opioid treatment are followed in methadone, and also that the program stays open and that the rules of the state and the federal level are both followed. And they have to be registered with the DEA, or the Drug Enforcement Administration. Next slide, please. But I think the thing that's really important to know is that OTPs are more than just methadone, right? So we do dispense medication, and that is what really gets the person engaged and is able to save their life. But they also provide a full array of treatment. And I think one of the things we're going to talk a little bit throughout this, though, is especially with the new final rule codifying this, is that the OTP is required to provide services, but the person is not necessarily required to engage in services in order to receive treatment. So, in addition to dispensing opioid agonist medications, and again, when we say more than just methadone, OTPs now can dispense buprenorphine and long-acting naltrexone as well. The required services include supervised dosing, toxicology testing, and again, that is for clinical use, not for punitive use, adequate medical counseling, vocational, educational, and other screening and assessment services. And so even if the opioid treatment program isn't providing that directly, what we'll typically see is the OTP has a connection with a vocational program down the street. They usually do have counseling on staff and educational services on staff. And they have to, and those services that they provide in partnership do have to be through a formal agreement so that there is coordinated care for the persons that are receiving services in the OTP. So we'll go into the update to the OTP standards, because one of the things that's interesting about, next slide, please, about how opioid treatment programs have evolved or not is that the 42 CFR was originally in effect in 2001, because prior to that, OTPs were regulated by the FDA, and it was really only looking at the medication. And so in the 90s, they said, how can we look at improving the quality of care? And they looked at moving that out of the FDA under SAMHSA using the accreditation model, and found that there was improvement in individualized dosing and individualized treatment planning and the services that were provided. And as part of that, they codified this all into the 42 CFR Part 8, what we often call the final rule. But that wasn't updated again until 2024, which we'll talk about in a little bit. So the CFR talks about the review of record keeping, the site for storage and methadone and buprenorphine, the inspection and testing of the safe where the medication will be stored, verifying state licensure, and verification of SAMHSA certification. And then February, after 23 years, we updated the final rule, and that went into effect April 2nd, 2024. And programs were allowed until October 2nd of 2024 to become compliant with those rules. The next slide, please. And so a couple of things that the updated final rule really modernized was it was really the emphasis on shared decision making. One of the things that we know, unfortunately, in addiction treatment, it used to be very top down in OTPs and in other settings, but really the new final rule really codifies that the decisions that are made should be between the clinical team, the medical team, and the individual being served. The treatment should really be individualized. When in the early days of OTPs, used to hear, oh, no, we never go above this dose. We never go above that dose. Any one person who's testing positive for this other substance is going to be having their dose lowered. Now it's really emphasizing that programs are expected to provide individualized care. It also really allows for the clinical judgment of the medical team on how people should be initiated and titrated and incorporates principles of harm reduction. And the reason for this is it recognizes that we need to meet people where they are with their opioid and other substance use disorders, right? Because most people that we're treating have more than one substance use disorder and help them make positive change. And even while they're on that journey, if they're continuing to use, helping them reduce the risk of harm. And next slide, please. So one of the first changes was to admission that used to require a 1 year history of opioid addiction. And so that has been removed, again, increasing access to care. It removes the requirement for two documented instances of unsuccessful treatment without a medication for people under the age of 18. It promotes priority treatment for pregnant individuals, and that's something that had always been there, even if someone's just receiving block grant funds, but really kind of codifies what's expected of a program and how quickly someone should be getting someone who is pregnant onto a medication. Allows consent for treatment to be obtained electronically. And allows for initiation of methadone after a screening examination and doesn't require the delay of initiation until a comprehensive examination is completed. And so basically, what the rule is saying, as long as you do an examination that shows that the person is safe to receive this medication, and this is the right medication for them, you can start that, and then the comprehensive physical examination would come later. Next slide, please. So, and this is something that came out of one of the things that happened during COVID, and around the time that these rules were being looked at, COVID happened, right? And so we started to have to look at all of these different ways to provide care. And so we saw that you could effectively deliver, do a screening examination via audiovisual telehealth. And this is something that folks in the field have been pushing for a long time, even pre-2020. So this was an exciting increase in access to care. OTPs can accept screening examinations performed by other practitioners if done within 7 days of admission and the OTP practitioner has verified it. So if they did see their primary care physician and they have a physical from within 7 days, or maybe something from a hospital, they're able to use that to get people initiated more quickly. The full in-person physical examination has to be completed within 14 calendar days. And while there is an expectation that counseling is offered, you cannot deny people medication who decline counseling. And so one of the things I think too is that we've been hearing a lot throughout the country, people saying, well, now we can't require counseling. Having done many, many CARF surveys at OTPs, I've never written a recommendation that says an OTP is out of conformance because a person didn't attend counseling. The OTP was always required to offer it, but the person, as far as like kind of the federal rules, the person was attended as needed. And so it removed the unnecessary barriers to medication by focusing on the individual's needs and as protections for vulnerable groups. And so, again, we want to see people using their clinical judgment and their clinical skills to provide motivational enhancement to the person to engage in all of the services that are available to them, but without using the medication as the stick to get them engaged. Next slide, please. The changes in methadone initiation, this is a really big one because we do know that frequently people would be initiated on methadone and the dose isn't holding them on the original dose. So and again, allowing for clinical judgment, the initial dose can go up to 50 milligrams on the first day. Previously, it could not go above 40 milligrams. Now you can still go above 50 milligrams if the provider provides appropriate documentation for the reason for the higher starting dose. And next slide, please. One of the other things that we learned from COVID was that we could increase the number of take homes that people had, and we did not see an increase in diversion or an increase in overdose risk, right? So we saw that people were able to engage safely and attending the clinic less frequently. And one of the things we've actually heard from some OTPs around the country is they were surprised to see that with the increased take homes, some of the people that they served started doing a little bit better because coming to the neighborhood where the OTP was, if there was a lot of use around there, was actually a trigger for them. So sometimes they did start even increasing the number of take homes as a safety precaution for that individual. So the previous rules were any patient may receive a single take-home day dose for a day that the clinic is closed for business. So that's often usually on a Saturday or a Sunday. Then the first 90 days limited to a single take-home dose each week. Second 90 days, up to 2 doses per week. Third 90 days, up to 3 doses per week. First year, up to 6 doses per week. After 1 year, 2 week supply. After 2 years, up to a 1 month supply. Anything outside of those parameters would require formal requests to SAMHSA and the State Opioid Treatment Authority. And then there was an 8-point criteria for consideration that were some clinical points that should be driving the team and ultimately the medical director, and not whether or not the person was eligible for take homes. Next slide, please. I will say, because I hate math also, that this makes things just a lot easier. So as you can see, the relaxed take-home restrictions are up to 7 days of take-homes in the first 14 days of treatment, up to 14 days of take-homes for the 15 from day 15 of treatment, and up to 28 days of take-homes from day 31 in treatment. And so the rationale for this was making permanent those flexibilities that COVID-19 allowed programs to have. So there would be wider access to methadone, and people weren't spending so many hours of their day traveling to the OTP to get their medication. And again, though, that this is paired with individualized clinical judgment, safeguards, and patient education. The clinical team and the medical team are still working together to make the decisions that are in the best interest of that individual. And now we move on to the exciting part of the mobile opioid treatment unit. So in 1988, mobile methadone units were first approved with the goal of expanding access to marginalized communities, because we know in many rural communities there's no access, but even also many urban communities there's not access in the communities that most need them, or people are not able to get to the program. In 2007, there was a moratorium on new units due to concerns about potential diversion. Then in 2021, very exciting thing happened. The DEA issued the new regulations related to mobile OTPs and lifted that moratorium. One of the rules was it has to be part of a fixed site OTP. And then they waived the requirement of a separate registration for that mobile unit. And then with advancements in technology, you're also allowing for engagement in counseling as well as medication dispensing. So we see a lot of really cool things with people doing, which is they might have the mobile unit and the person can engage in a telehealth session from that unit, or they can engage in telehealth from home, but come to the mobile unit to get their medication. So we see lots of really cool things of how people pair counseling and medication to make sure people have access to all of those services. And now I will turn it back over to Dr. Alfonso to take us through the models for mobile OTP operations.
Okay, we can go to the next slide. So there have been different ways. There was actually a report that surveyed several people who were providing OTP services, kind of state and local health authorities, and looked at what types of things people were doing in the delivery of mobile OTP units. So one thing, people were partnering with facilities that had higher prevalence of individuals with opioid use disorder. And so that could be correctional facilities, jails or detention centers, prisons, skilled nursing facilities or long-term care facilities where individuals who may have had some type of medical complication associated with their substance use and require ongoing subacute care, partnering with those facilities so that individuals can get their subacute treatment, but also continue with medication. And then residential addiction treatment facilities, for many years, people were not, even in residential addiction treatment, people were not able to access what we know are life-saving medications. And so one of the first ways that people increased access was to partner with residential addiction treatment facilities and just park their unit there outside of that so that people could come outside and get their methadone. Next slide. Another model is to partner with organizations that are already serving those with opioid use disorder, specifically harm reduction organizations or syringe services programs. So partnering with them. So if they've got a van and if the syringe exchange van is out in the community, having the mobile unit come and park alongside the syringe services van and provide services. And what we know, the data actually does show that individuals who are engaged in harm reduction services, specifically syringe services programs, are more likely to enter treatment. So, and you just make it easier if you've got the mobile unit right there with the syringe services program, or other recovery organizations or drop-in centers, etc. So organizations that are already serving individuals who are known to have opioid use disorder. Next slide. Targeting populations with high need. And that's exactly what AFBSS is doing, right? So using your data to target individuals who have high need for medications for opioid use disorder, and being intentional about taking your services to those individuals. And that could be, as was already said, individuals who live in rural communities who may have to travel many, many miles to be able to access an OTP, urban residents with limited transportation. So, I'm in Baltimore. Um, Somebody from West Baltimore could sit on the bus for 2 hours or more just to get to East Baltimore. And so, yes, it is an urban city, but transportation, particularly for individuals who don't have their own transportation, can be quite limited or result in a long period of time, people spending a good portion of their day in the commute. And so using data to identify what communities might best be served by a mobile unit, tribal communities, and then also individuals experiencing homelessness, and particularly unsheltered homelessness, either in encampments or day shelters as well. So next slide. And then what types of services? So in addition to thinking about the model, or what population you want to serve and what model, who you might be partnering with to deliver these services, you also want to think about what services are you actually going to deliver on the OTP. And that varies dependent upon organization. So some organizations limit their distribution of methadone to those who are already on methadone, while others decide to both initiate and continue ongoing treatment for people. Count, are you going to add counseling to your mobile OTP services? And again, with the advance in technology and the ability to do telehealth, you can do that even with not having a counselor on the van. So again, using telehealth to link to both medical providers and counselors, vocational counseling, housing support, and then medical services. Some units are also pairing their mobile OTP services with other medical services, including testing for HIV and hepatitis, wound care, etc. Next slide. So we talked a little bit about kind of the rules governing overall treatment in the OTP, and particularly those updated final rules that were released in February of 2024. Now we're going to drill down specifically to rules governing how treatment is to be done using a mobile unit. We can go to the next slide. And so first we're going to start with kind of the federal requirements. So starting with the Drug Enforcement Administration, or the DEA. So when the DEA originally released their guidance on mobile OTPs, you can see that their intent was also to expand access. So to allow for greater access for individuals with OUD who are unable to access either because of geographic limitations, mobility issues, etc. So everybody's looking to expand access to treatment. With the 2021 rules, again, they were very clear that any mobile OTP has to be connected to a brick and mortar OTP. A mobile unit has to be connected to a brick and mortar OTP, and it has to operate within the same state as that brick and mortar OTP. It cannot cross state lines. It is expected to return to the registered location. So again, that brick and mortar OTP every day. Now, again, depending upon where the OTP is, parking a mobile unit in front of the OTP or on OTP property may not be accessible. If you think about urban communities, So if you're not able to park it at the registered location, then you've got to find an identified space has a fenced-in location, and you have to meet all the DEA security requirements. So you have to be in communication with your local DEA agent and get approval. And specifically, you got to make sure that all substances are removed for the mobile component at the end of the day. And again, the local DEA office has to be notified of where the unit's going to be parked overnight, and they have to approve. And then even if you are able to return the mobile unit to its registered location and park it there, regardless, all substances have to be removed and then secured within the registered location. So taken off the mobile unit, taken back inside the brick and mortar and locked up and secured. Next slide. Um, Okay. So the other thing to know is that just like a brick and mortar OTP has to have a safe, and the DEA is very specific on the requirements of that safe and the thickness of the safe, etc. Similarly, mobile OTP units have to have a safe that must be installed and secured. And the DEA is going to, when they come to evaluate and approve the mobile unit, they're going to look at that safe. And they are very specific is that when the unit is en route or in motion, all substances need to be secured inside that safe. So going to and from the locations where medication delivery is going to or dispensing is going to occur, medication has to be locked away and secured during that transport period. The unit has to have an alarm system. If there is a seating or reception area, so depending upon how the unit is designed, some do or some do not have reception areas. If one does exist, that reception area or seating area must be separate and apart from where the medication is being stored and dispensed. And if not, patients must wait outside. The DEA is agnostic on whether you have to have armed or unarmed security. They leave that completely up to the OTP. And then programs must have a standing operating procedures and a contingency plan for what's going to happen if the unit becomes inoperable for some reason, whether it's involved in an accident, hopefully not, or whether it gets a flat tire or the engine goes out, whatever it is, there's got to be a contingency plan for what's going to happen if that unit becomes inoperable, including how those medications are going to be taken off that unit and returned and secured at the registered location. Next slide. So those were the DEA regulations. Now we're going to talk specifically about California's Department of Healthcare Services regulations. So in January of 2024, DHCS actually released guidance on mobile NTP applications, implementation, and operations. And there was actually an RFP that was released that allowed for expansion of OTP medication units and mobile OTP or NTP units, as they are referred to in California. Again, with the goal of increasing access to specific populations. And those populations included individuals in rural areas, justice involved or criminal legally involved populations, indigenous and native communities, individuals who don't have transportation, and then areas that don't have an OTP within close proximity. So again, if you think of essentially a treatment desert. So those are the target populations for DHCS. Next slide. And so they've released a BIN, so BIN 24005 gives more information about the application and the protocol requirements for individuals wanting to operate a mobile OTP in California. And so in the application, you have to explicitly state what geographic areas are going to be served, and that includes specific addresses. So where is the unit going to be parked? The address for where the unit is going to be parked, the name and job titles of staff members who are going to be working on the mobile unit and who will have access to the safe. And associated resumes. So in addition to names and job titles, resumes are expected. Description of methods for transporting the medication between the registered location or the brick and mortar OTP and the mobile unit. Schedule of operations. So where's the unit going to be? what days and times. So not only where is it going, but when is it going to get there? How long is it going to be there? And what are the hours for dispensing? So all of that information needs to be included. And then a written statement and a map. So including the route that's going to be taken to and from the location. So again, specific address, when you're going to be there, how long you're going to be there, and how you're going to get there are all things that need to be that DHCS is going to be looking for in terms of a mobile unit. How are you getting there and how are you getting back to your dispensing locations? Next slide. And so additional things that are expected. So a diagram including essentially what the mobile unit looks like and how it's laid out. So essentially almost if you think about like a blueprint of the diagram and explicitly looking at where that medication is going to be stored and the measurements of the safe in which it will be stored. An estimate of the number of patients that are going to be served on the mobile unit and a description of how, remember Debbie talked about all the additional services that are expected to be delivered in the context of an OTP. So there needs to be some description of how people are going to access those other services if they're not being delivered in the mobile units. Again, how medications are going to be accounted for and tracked. And then just as the DEA required a contingency plan for if the vehicle became unoperable, DHCS is also looking for written policies and procedures for unforeseen circumstances, natural disasters, etc. So all of those things are going to be required when you're looking to put a mobile unit out on the street or wherever it might be, wherever you're going to take it from the brick and mortar, or in the mountains, etc. So next slide.
We're going to talk about increasing engagement and low barrier treatment using mobile OTPs. Next slide, please. So when we do that, we really want to think about the way we engage in terms of harm reduction and SAMHSA's previous definition of harm reduction, because we know that even if we take the medication to the individual, they're still not going to come if we don't engage them in a way that centers what their needs are and put the unit in a place that's acceptable for them. So centering us on what SAMHSA's previous definition of harm reduction was, a practical and transformative approach that incorporates community-driven public health strategies. So including prevention, risk reduction, and health promotion. I think that's something that's really important for us to remember when we talk about harm reduction is it doesn't just benefit the individual that we might be engaging in safer use or in reducing their harm. It's a benefit to the community at large, right? Because we're reducing the risk of infectious disease transmission and other harms that might happen to the community, to empower people who use drugs and their families with the choice to live healthier, self-directed, and purpose-filled lives. So that shows us, right, that just this cessation of use is not the only thing we're trying to achieve, right? We want them to decide their recovery path, to decide what's working best for them, and for this all to come from the individual and centers the lived and living experience of persons who use drugs, especially those in underserved communities, in these strategies and the practices that flow from them. And so where we think of times we think of the traditional treatment system, particularly OTPs, because they've been such a regulated environment, it's often very much driven by the treatment program and not necessarily by the people who are using or who need to use those services. So this is kind of changing how we think about designing services in the treatment system. Next slide, please. And so in the 42 CFR Part 8, in the updated rule, they codify the expectations of harm reduction. And that includes overdose education, so helping people with safe use supplies, overdose reversal medication, distribution of legal drug checking supplies, so fentanyl test kits, particularly for people who are using stimulants, xylazine testing kits, all of those other adulterants that we're seeing out there, infectious disease testing and intervention. So that's still one of the expectations of an OTP is screening for HIV and other STIs and Hep C. Counseling and risk mitigation. So we're moving from that kind of counseling that where might be the approach and purpose might have been to solely to stop use to what do you want and how can we kind of help you achieve those goals. And so it might be reduction in use, it might be less spending, it might be just using more safely, right? And so hopefully then we're engaging the individual to stay with us in services, linkage to other public health services, connection to peer and recovery supports, and addressing basic needs, food, hygiene, housing. We know when people have their basic needs met, they're much more able to engage in treatment and in recovery. And then the next slide, please. So I think one of the other things that's really important to remember is that harm reduction goes beyond overdose and risk reduction services. So we often kind of talk about when we're working with programs on kind of developing a more harm reduction focus, they'll often say, yeah, we give out Narcan and, sometimes we give out test strips, but they're doing that saying, here, don't use. Or they're having a harm reduction group that's for people who are still using, but the real sole purpose of it is to kind of tell them not to use. So it really goes beyond those supplies, even those are life savings, to how you engage the individuals in these discussions. And that includes how you develop the relationship. So centering on that, engaging and listening where they are, treating individuals with dignity and respect, and remembering that they are the driver of their own lives, and meeting people where they are. So if they're where they are right now is not really wanting to completely stop using, but they might want to reduce some of the impacts of their use, meeting them there and helping them reduce those impacts while staying engaged with them and helping make sure that they have access to the medications that will help them to stay alive. And I will turn it back to Dr. Alvanzo for the framework for engaging persons.
Okay, and we can go to the next slide. So kind of just building right on what Debbie talked about, recognizing that for any behavior change, including changing one's substance use, there are stages of change. And that change is gradual and it is not always continuous. And people may make the change and then have recurrence. And so recognizing that change is gradual, and it's important to keep that in mind. One, that change is possible, but inevitably it's going to take time. And it's important to keep in mind that in addition to one's addiction, there are often other underlying factors, whether it's trauma, lack of access, stigma, etc., that will also need to be addressed and will need adequate time and resources to effectively address. Change is cyclical and constant. So it's a process, it's an event. As opposed to an event, it is a process. And for people who use drugs, it's important to keep in mind that many have the power to make the change, but often lack the resources to support them in making that change. And so by expanding access via mobile unit, we can be part of that solution. That change is progressive. Again, there are steps, but that people may move up and down those steps. Recurrence is likely. Actually, when we talk about addiction, we talk about it as a recurring remitting disease, which most chronic diseases are. But recognizing this also challenges the notion that a recurrence is a failure, right? And so recognizing that recurrence we're discussing it in a way that does not further shame the individual, and we're discussing as part of the process and still progress. And so, and particularly people's ability to recognize a recurrence, and maybe it's shorter than the previous recurrence, recognizing that there's still progress and not shaming the individual. And then again, meeting the individual where they are, recognizing that I may have, as an addiction medicine physician, I still practice a half day a week. I may have a certain goal or a certain expectation of a certain stage I'd like a patient to be, but they may not be there yet. And I've got to recognize where they are and meet them where they are. And that's kind of, again, builds on, this is the stages of change, but it also goes into the harm reduction framework as well. So we can go to the next slide. So when we think of kind of core principles of engagement, so one, first we're going to start with safety of the individual comes first. So recognizing the individual, recognizing that we need to treat individuals with respect and dignity. And that includes individuals who may not be ready to receive our services or may not be ready to receive all of the services. So maybe they're ready to receive medication services, but they're not ready to engage in counseling or some of the other services yet. Still treating them with the same respect and dignity that we would all other patients. Ensuring that they understand and can consent to services, and again, making sure that they are included in the decision-making process. Recognizing that there are multiple pathways to recovery, and that we should be using an individualized approach. Again, recognizing that those changes in the final rule allow for more individualized treatment and allow for more clinical decision-making. Engagement should be supportive and not punitive. Again, recognizing that when we are punitive, and particularly punitive to the point where we are disenrolling individuals from our services, we've lost any ability to continue to engage them and support them or to motivate them to change their behavior. And then recognizing that we need to collaborate, right? So the more partners we have who are doing this work, and the more people that we can people and organizations that we can partner with to serve individuals, recognizing that they often have a multitude of needs, then the better the outcomes are likely to be for the individuals with whom we're working. Next slide. And so now we're going to talk a little bit more about taking that framework and applying it in the clinical setting, particularly the clinical MTP. So next slide, we'll talk about creating an environment that is engaging. So starting with a non-judgmental environment in which drug use is acknowledged and accepted. So recognizing again that my goal may be for the individual to stop using all substances. That may not be their goal. And I've got to acknowledge that, accept that, and continue to work with them regardless of that their goal may not be complete remission or abstinence. Writing and enacting policies that reflect this reality. So again, leaning more to how can we best support the individual as opposed to leaning towards punitive responses. Again, including dialogue, and ideally a safe dialogue between the providers and the people that are being served, and strong feedback loops so that we are hearing from the individuals that are being served in our programs and taking that information that they provide and using it to modify our service delivery to best meet their needs. Again, and when people are involved in their own care and feel listened to and supported, then they become your best advertisement, and they're going to spread the word about your services, and feel more supported to take steps to improve their own well-being, but also the well-being of other members of their community, right? And particularly other people with whom they have often used in the past. Next slide. And so now I'm going to talk about low barrier treatment and what that really looks like. So a lot of times we'll hear low barrier treatment, but what does that mean? So low barrier treatment means it's individualized. We've already talked about it. Harm reduction is at the center. It's accessible, flexible. Again, not tied to mandated receipt of counseling, not tied to abstinence, and it's delivered by trusted partners, meaning that you are establishing a rapport and establishing a relationship with the individual and becoming a trusted partner in the community. Next slide. And so when we think of traditional models of treatment, where traditionally we've stood up a building, a brick and mortar building, and have expected individuals who are dealing with substance use, often co-occurring mental health disorders, all the social determinants of health, to walk through that door at the appointed time that we say we're open. And then we want to know why people are not accessing services. And so we want to think about how can we allow for treatment when the person is ready for it, at that appointed time. So it's ideally same day admission to treatment and access to medication. So in my background, I didn't say that I spent 4 years as a medical director of an OTP when I was on faculty at Johns Hopkins. And there are still opportunities for improvement. So people would come in, they would not necessarily get medication the same day. That has improved over time, but if somebody comes and recognizes, we just talked about those stages of change and how motivation fluctuates and people can be ambivalent. If somebody walks through the door, makes the takes the step to walk through the door, this was in the brick and mortar setting, but in a mobile OTP setting, takes the step to come up to your mobile OTP and then are told, we can get you on medication in 3 or 4 days, you may have lost that individual. And so same day admission to treatment and same day access to medication. And we should not be withholding that medication if they decline to participate in other services. We know that MOUD is life-saving. And so we should not withhold what we know as a life-saving medication because they're not participating in counseling. We also know that, again, goals differ. We should not be discontinuing medication because somebody continues to exhibit the symptoms of their disease. And so if somebody continues to be positive for opioids while they're being treated with MOUD, it may mean that maybe their MOUD is not as effective and we need to adjust their dose, but we don't want to kick them out of treatment. And then again, these other services should be offered but not required. Next slide. MOUD should not be denied because somebody's using other substances. Treatment scheduling should be flexible and allow patients to meet their other obligations, whether that's work, school, childcare. And then the length of time for MOUD should be individual and recognizing that for many people that may be indefinite. Next slide. And then again, just want you all to take, as you're thinking about rolling these services out, think about what you can add in addition to the medication and counseling. You're going to be working with a high need, high co-occurring patient population. The more they can get in the same place at the same time, the better their outcomes are going to be. So, is there the opportunity to add PrEP or medications to decrease their risk for HIV transmission, testing and treatment? Connection to primary care. If you're is there the opportunity to also provide medications for psychiatric treatment, vaccination? So what other services might you also be able to provide on your mobile OTP? Okay, next slide. Barriers and benefits to implementation. Next slide. So in terms of barriers to implementation, often it's power dynamics, right? We talked about how regulated OTPs are, and there are inherent power dynamics in that. And so being mindful of, are there opportunities to mitigate some of those power dynamics? Being mindful about our policies and not being punitive, being more supportive. Sometimes it's the ego of the individuals who are engaged in delivering the services. And a big, big barrier is NIMBYism. So NIMBY is not in my backyard. Community opposition and stigma to having services in one's neighborhood. And so we need to educate people in the community as well. Next slide. And then specifically dealing with a mobile unit. Again, we talked about the specific requirements about where the unit has to be parked, weather, and sometimes terrain can be a challenge, and then maintenance. These units are going to require regular maintenance. And so those are potential barriers that you're going to have to think about as you're planning services. Next slide. Next slide. And then there are just a number of clinical impacts that these services can make in your community. And we'll just, in addition to improving clinical relationships, increasing patient retention, and strengthening trust between members of your community and members of the treatment team, among others. Next slide.
All right. So a couple of the things to be thinking about when you are planning for your mobile unit. So identifying the need, where are the people that most need this service that aren't able to access it? So we see services talking about, or programs really talking about delivering services in the mountains or in encampments. We've seen some things about down by the river or down by the levee where people are most in need, and any service cohort. So thinking about what are some of the other risks and services that people might need. When, as Dr. Albanzo was talking about, really, how do you partner with existing services? So if you have a syringe exchange service that's already going out and delivering services, how do you partner with them? Many of you are partnering with shelters and or potentially the county HHS. So if people are coming anyway to fill out their Medicaid applications, they're to fill out applications for SNAP benefits. How do we bring those services in? Syringe service programs. And so one of the things, even when we had a brick and mortar OTP, one of the ways that we really increased our volume and our census was by partnering with syringe services and having people that were over there kind of building some relationships so people felt comfortable coming to us because they trusted their syringe providers. County level barrier services and barriers, contracting and service payment and opportunities for value. So we know that contracting in California can be very county specific. So how do you really negotiate for these services and help to understand what the cost is of delivering mobile services? And then also thinking about are there opportunities to say to your county or to your payers that, you know what, we're going to bring a lot of value because we're going to also be doing prep for this very hard to reach population. So we'll reduce infections, or we'll be doing HIV or Hep C treatment in a lower cost setting. And so we're likely to reduce your spends. Next slide, please. And so some of the things to think about is open access. So how do you, as Dr. Alvanzo was talking about, have services that people can access quickly and medication same day as much as possible? And this is one of the requirements of AFBSS is open access. And so I remember sometimes even if someone had to wait 30 minutes, I would say to them, please just wait. The doctor will be with you in a few minutes. And they would be on the phone with their drug dealer and out the door, right? And so we know that people are often need them when they may have that window, we want them to get in right away. What are the steps from first request to first dose? Having been a very regulated environment, OTPs often create forms and forms. And I remember people would often say, well, this is CARS requirement, this is SAMHSA's requirement. We're like, actually, it's not. It's how you've interpreted it. So really breaking down what is it the minimum that's needed to meet the regulations and to make sure this person is safe for the step to from when they have that first dose. Where is the biggest need? So we heard some really interesting places like Slab City, at the shelter, all of these different places where people might be residing or kind of living their lives and not able to have access to the medication. Also, where people living maybe who are older adults who have so much challenge ambulating that the medications need to come to them. And then who are your strategic partners? So we saw many of you talking about shelters that also could be access into the brick and mortar. People are going to need more access to more intensive services. And the other piece of this for the strategic partners is not just where you place the unit and where you deliver the services, but who is going to be the biggest advocate for this use, right? If you put it with this with a shelter or with a residential treatment program or a skilled nursing facility, are they going to make sure that the people are getting access to this?
Thank you everyone for tuning into this webinar. If you have any questions at all, please feel free to reach out to our team at info@afbsstraining.org. Thank you so much and have a wonderful day.